Thank you very much.
Nicolai and Evosep, thank you very much for giving me this opportunity to give a talk about why, how, and when mass spec-based proteomics in laboratory medicine. So as you mentioned, I'm an associate professor at CPI in Mathias Mann's group, but I'm also a physician at the Department of Clinical Biochemistry at Rigshospitalet. So I'm really excited to talk about this because this is one of my favorite topics in life. So just to remind you all that proteomics is of course the study of many proteins, and the closer we get to the proteome, the more complex it gets due to isoforms, post-translational modification, and so forth. And a huge hindrance, I believe, is the immaturity of the technologies that at least compared to those that are used for genomic, which are, I would say, much closer to clinical application in real life. So this is a major hindrance. So I just wanted to start out by discussing a bit about clinical diagnostics. Of course, as a physician, we have our patients, and what we do is that we talk with them, of course, we take their history, we do clinical examination, we do laboratory medicine, so that means blood samples or CSF samples, or what can it be. You could do imaging, and you can also do pathology. So my talk is centered about laboratory medicine, and laboratory medicine, as mentioned, is simply a diagnostic of disease by analysis of body fluids and or tissue biopsies. At Rigshospitalet, we roughly perform 10 million analyses, and those analyses ranging from something very simplistic as blood glucose measurement to more advanced data streaming as clinical exome sequencing. So I hope here in a few years we will add clinical proteomic as well. So what is actually the use of mass spec-based tools in clinical diagnostics? The current focus is on small molecules, so D vitamin. I'm sure that most of the attendees here today have actually had measurements of D vitamin. Toxicology, pharmacology is another one, and finally hormones such as the androgen status. So that's the three typical examples. But there are no proteins, so this is something we would like to change. So my good friend and colleague Philip Geyer has made this a pie chart where he tried to show that indeed the majority of actually used biomarkers are actually proteins. So if we imagine that we took a blood sample from one of you guys, or perhaps myself, and we use some sort of technology, it could be Evosep, it could be coupled to LCMS, it could be a different thing, a different technology, but the idea here is that we have circulating proteins in our blood. Some of those are in high abundance and high in concentration, as shown here by albumin. It's a reflector of liver status. And of course, C-reactive protein is one of the medium abundant proteins that circulates, are used on a daily basis in all GPs departments and every internal medicines departments to monitor inflammation and infection. And finally, cytokines and hormones, which are the low abundant proteins. So the entire trouble with this dynamic range is that by mass spec we want to measure the jumbo jet being the albumin molecule, but we also would like to see if we have one or two CRP molecules or one or two insulin molecules in the solution, and that could be illustrated by the feather. So this 10 orders of magnitude that comprises the plasma proteomic the dynamic range is really one of the major challenges. So Philip, Matthias, and other persons, including myself, have been working to make a robust platform here that is, as Nicolai said, is not only but robust, but it also enables the user to go from patient material to some sort of conclusion within a couple of hours. And I think that is one of the major importances for using this in clinical diagnostics. So there are several reasons why I think we should use MS-based proteomics in the clinic. I think something that we perhaps do not talk too much about, that is that the entire understanding of clinical diagnostics is moving towards, it's a bit fluffy, but personalized medicine. And there it's simply not sufficient just to measure a single biomarker, because actually the patient that you expect having disease A could also have disease B at the same time, or perhaps it's another disease. And by being so focus, you may actually circumvent some clinical useful information. So that is sort of another approach to clinical diagnostics. And finally, as I will also discuss a bit later, that is actually there's a lot of what we're doing in laboratory medicine that is visual based interpretation. And how can that be in 2022? That's something we want to change as well. So why hasn't this been done before? Well, a lot of people actually have been trying to roll out proteomics in the clinic. I would say that a major hindrance has been immature technology, and a lot of different groups and people have been involved in trying to make mass spec-based approaches much more robust. The Evosep one is just one example. Of course, also the bioinformatic workflow afterwards is also a major importance. And here I think illustrated by Alberto Santos' nice work on the clinical knowledge graph that is just out now. So one of my vision in life is to investigate, explore, you could say, if MS-based proteomics can improve clinical diagnostics, and we really want to push this in routine diagnostics. So not, of course, there is a close balance between science and clinical diagnostic, but here we really want to tip towards the clinical diagnostic. Where are we doing this? Well, we're doing this as a collaboration between the CPR, the Novo Nordisk Foundation Center at University of Copenhagen, is located here. And just across the street, we have Rigshospitalet. You should come visit us. It's a beautiful view here. We have the lakes with a lot of good bars and restaurants, but this is where we are working. And there is actually also a tunnel, so you can go from one street, from one department to another in just 5 minutes. It consists of a team here listed. You probably know some of them, and we actually work as a team because it's important to emphasize that there are different expertises in the academic institution as CPR, but there's another sort of understanding of what is diagnostics at a diagnostic center, such as Department of Clinical Biochemistry at Rigshospitalet. So the merge of those two institutions, I think is really crucial. How and when? Well, in 2019, we had the formal agreement signed, and in June 2022, Lilia, who is spearheading all these, at least the technical efforts here, getting the machines to run, and Matthias, as you can see here on a site visit, we had it installed, and here in 2 years later, or less than 2 years, we have been involved in more than 20 different projects, and we think we have at least 2 projects that could be selected for clinical implementation. We have run over 5,000 plasma proteomes. So I think it's going at least in the right direction. One issue in, I think, in clinical proteomics, that is the lack of quality assessment and controls. There are no quality program that exists. Normally, when we do measurement of, let's say, a liver enzyme, we have an internal and external quality program. That does not exist, so that's something we need to discuss, I think. Furthermore, there are no validation report that fulfills the criteria for example, the Danish Accreditation Fund. Of course, they have other names in different countries, but the basic are the same, and you need to fulfill those guidelines before you can actually use it, at least in a Danish healthcare system. Quality controls is important. I wouldn't touch much about that, but that is just, of course, batch corrections and variability. And finally, a reference proteome, meaning that if you have a patient and you want to say, well, if is the reference interval for protein A, B, C, and D, is that increase or decrease compared to reference? Well, we don't have so. So we've been trying to do so by integrating a lot of data from 250 participants from the Danish blood donor study. So these are just some of our ongoing and forthcoming projects. Personally, I'm really into the first 2, and I will show you a bit more data about the first one, which is diagnostics of multiple myeloma. So let's have a look. So can we do things better for patients with multiple myeloma? So let's just have an idea about the disease first. It's actually that around 1% will develop multiple myeloma. I just had a meeting with some Icelandic researchers who have actually screened the entire Icelandic population for preconditions of multiple myeloma, and this may actually be higher, so at least the preform. So I think this is actually almost a common disease that we should be more aware about. It's caused by uncontrolled proliferation of anti-producing blood cells. So that is the transformation from plasma to B cells or to plasma cells. And the entire diagnostics of, or part of the diagnostic of multiple myeloma is based on what is called the M component. So that's the monoclonal antibodies. So let's have a look what happens if you do have multiple myeloma. So these are different x-rays, and you can see there are some black holes here, and they should not be there. So that is the bone complications that occurs. Also, these individuals are suffering from frequent infection, anemia, so blood loss, and finally kidney issues. So this is a multiple organs disease. So what is the M component? Well, it's actually a myeloma protein. It's an abnormal antibody or fragment that is produced in excess amount. And what do we do to characterize them or diagnose them? So the golden standard is currently capillary electrophoresis, and you can get a answer yes and no. This is visual based, as I will just show you in a minute. And finally, subsequently, if the answer is yes, we can do immunosubtraction or immunofixation. And these technologies sounds a bit old school. Let's have a look. So this is the capillary electrophoresis. This is just for one patient, and this is the albumin top, and then we have some of the other beta and fragments and so forth. And where the M component comes in is typically in this direction. And actually, what we do here is that we manually, visually isolate this peak as a potential cancerous overproduction, and then we integrate the area under the curve, and this is how we do the diagnostics of M component positivity or negativity. As you can see, it takes a lot of time, and it also costs a lot of money. So if it is positive, we do immunofixation. This is an old school gel, and you can see for this patient, you have a immunoglobulin G with a kappa light chain, and this is actually not so easy to just to go into and say, is this is it a positive patient or is it a negative patient? So in at least in our hospital, we have two persons that are need to survey each of those analyses. So this is really time and personal resource consuming. So this is just to summarize the current diagnostics: capillary electrophoresis, if it's positive, then classification by immunofixation. What we have done is trying to compare the conventional golden standard diagnostics by mass spec-based proteomics, and we had a match sort of a negative and positive for the M component, and then we did sub-classification of those individuals. So just a brief data highlight from these studies. There are much more. The first one, I would just like to emphasize a ROC curve. For you to get that picture, perhaps you already know it, but I didn't know for some years ago. So a ROC curve is a receiver operating characteristic. It actually tells you, informs you how good is this test, the accuracy of this test for the patient, how good is it? And if we just have an example of, for example, do you have fatty liver disease or liver cirrhosis? We use liver enzymes, and they have a ROC value of 0.6. So what can proteomics do with multiple myeloma? As you can see here, I think we have a pretty high diagnostic accuracy for multiple myeloma of 0.94, at least for the M component. And we are even better at actually providing sub-classification. And what I think is really, really important to emphasize here, that this is done in one step, and it's not visual based. This is AI based algorithms. So we sort of jumps over the personal 1-2 individuals that needs to evaluate the respective curves, as I just showed you, for the capillary electrophoresis, but also for the immunofixation. So I think this is just one out of many examples where I think mass spec-based proteomics can actually improve the current clinical diagnostics. So this is how it looks like. And our next goal here in 2022 is to try to benchmark and potentially also implement this workflow for diagnosing multiple myeloma in Denmark. We have a different range of activities here, also for mineral residual disease and for subclasses of multiple myeloma, MGUS and smoldering disease. So just a brief summary of what I have been talking about. We've been trying to have a mass spec-based technology in the clinic, and we have different examples of where we believe that this technology is superiority to current, but actually may also provide additional clues, and that's in particular the truth for viral and bacterial infections that I would like to talk with you about for hours, but that's not possible today. There are still some hindrances. One of them is absolute quantification, and the second one is a quality program. I think those two are something that we and others are working on, so it's likely something that is manageable. So, and my end conclusion is really that I'm still a believer that mass spec-based proteomics can do something for patient care by enhancing, but not perhaps only enhancing, but also being faster and more reproducible compared to the golden standard clinical diagnostic as outlined for multiple myeloma. And with that, I would just like to acknowledge my colleagues and thank you guys for listening. And I'm happy to discuss these aspects with you afterwards. So thank you to Evosep and Nicolai.